And I was really struck by how unhealthy a lot of Britain is. And in terms of my emotional baggage from coming out of frontline action against the pandemic, I'm really trying to figure out what we do about that as a country.
I think fundamentally it's one of our largest, if not the largest, health problem. Fortunately or unfortunately, we tend to concentrate on specific disease areas rather than cross-cutting issues in healthcare. Hello again and welcome to Innovating Healthcare. Today we're going to be talking about the UK obesity strategy, and I'm very pleased to welcome my three guests, Sasha, Steve and James. Is that all right? Can I call you James?
Of course.
Okay. And I'm going to let them introduce themselves at first into their backgrounds. Then we're going to go through, I hope, a really fruitful discussion on the management of obesity, but more importantly, the societal element of obesity and how we're going to, across different departments of government, look at how we're going to reorganise and replenish our youth with a fitness protocol rather than a deliberate way, as I can see it at the moment, of causing them harm without some useful interventions. So, should we start that end of the panel?
Thank you, Mike. Pleasure to be here. I'm Sasha Karakusevic. I work with the Horizons team, which is a small team in the NHS that focuses on complex change projects.
Thanks so much. Yeah, great to be here. I'm Steve Mann. I'm director at 4Global. 4Global, we believe in sort of harnessing the power of sport and physical activity to tackle big societal issues. I'm looking forward to a great conversation.
And James.
I'm James Bethell. During the pandemic, I was Minister for Innovation in the Department for Health. And I was really struck by how unhealthy a lot of Britain is. And in terms of my emotional baggage from coming out of frontline action against the pandemic, I'm really trying to figure out what we do about that as a country.
I think fundamentally it's one of our largest, if not the largest, health problem. Fortunately or unfortunately, we tend to concentrate on specific disease areas rather than cross-cutting issues in healthcare. And your experience together as two organisations, a private and public organisations working together on physical activity, I've read your paper, it's wonderful, and it's really interesting that it concentrates on physical activity for everyone. Could you just take us through what that showed?
Yes, sure. We started working on physical activity as a project with colleagues in what is now OHID, the Office for Health Improvement and Disparity. And it's a really interesting project. The challenge was, how do you get the NHS more interested and involved in physical activity? We found quite quickly it's not just about more guidance. Early discussions showed that most of the barriers are at the outer boundary of the NHS. So how the NHS interacts with local communities, how the NHS interacts with local authorities, how it interacts with clubs and societies and the sports sector. And we've been working to understand that more and building a partnership with people operating in those other spaces, which is how we came to connect with Steve and colleagues in 4Global.
And Steve, what's your experience of that?
Yeah, it's been a fascinating process to go through. So at 4Global, we work predominantly with local authorities, sports, the sports sector more generally. So, but I've always been trying to tackle that issue of how do we get this sector that can be so powerful. We know how important physical activity is in sort of treating, managing, preventing chronic conditions, but we've never really been able to break down that barrier of the NHS and be part of that kind of frontline service. So that's the kind of where sort of Sasha and our sort of ambitions aligned really was, well, how do we get this front and centre and make it much more usable and accessible for people referring out of the health setting, but also for people to find themselves individually.
So when I was a GP, I couldn't prescribe exercise. That happened after I left general practice, but even so, it's still not a prescription for exercise. It's only those people who come through your door. It's not the population we're treating. So James, I'm just going to come to you transiently. We had some bad news last week around funding and an obesity strategy. We still have the problem. So what are policymakers thinking of now in terms of how we go about this, how we approach this problem?
It was bad news. And what's so frustrating to me is measures on bog-offs, on promotions in supermarkets and on advertising. These were the tiniest of fairy footsteps needed to crack this problem. Because the answer is going to be a lot more than anything that just the NHS can do. If you look at the battle against smoking, that's been 30 or 40 years since we categorically knew about the dangers of smoking, and yet we still have quite a large smoking contingent, particularly amongst areas of deprivation within this country. It's taken far, far too long to squeeze smoking habits out, and the hit we still have from smoking is profound. Obesity, I just don't want us to be here in 30 or 40 years' time wondering where the obesity strategy is going to go. And if we're going to be effective, that means getting education behind us, getting sports behind us, getting housing behind us, getting our food strategy correct. So the hit we took last week was frustrating, but it was really the first of a great many steps that we need to take as a country in order to achieve what we need to do.
So you mentioned this sort of cross-departmental, and in truth, obesity is everybody's problem. And I know that sounds like an old cliche from previous issues like drugs and such. But there are some pathways that we could probably follow, like smoking cessation and involvement and understanding the psychology, if you like, of the obesity epidemic. I work with a group of people that do educational materials to train professionals in how to manage obesity. Now, I at medical school, I can't ever remember that. Now, I'm of an age now, perhaps we didn't need it. We all played rugby, we all did sport actively. But, our waistlines have gone up considerably since that time, and that statistic that came out last week around there'll be more people in the obese category than in the slim category soon.
Yeah.
It is really quite haunting because we're looking at chronic morbidity like we've never seen before. If we can't galvanise ourselves post-COVID with the risks that we had there, how are we going to get this across to the population in a way that involves them? And maybe I could start with you, Sasha, on that one.
Yeah, it's a very good question. James's comments on smoking remind me, my background's dentistry, and interestingly we found out that sugar causes dental decay at about the same time that we found out that tobacco caused lung cancer, almost within 3 or 4 years. And we seem to have made much more progress on smoking, despite there still being a problem, than we have on this. And I put that down to the level of alignment and how communities understand what's going on, and how you make it relevant. And what's coming through this work is that's really tricky. Every community is a bit different. They've got different interests, different ways of getting things done. So in terms of translating a national policy into local action, that's what we are working through to discover at the moment.
And Steve, you work with a lot of physical coaches and people working in gymnasiums and things like this. Do they appreciate the problem? Are they trying to do something about it at a local level?
Yeah, they certainly do. And I think, as a physical activity sector, we work with over sort of 1,200 leisure centres, for example, that sit right at the heart of communities. But they're often quite scary, intimidating places for people to get into, and that's something we recognise as a sector, probably 5-6 years ago, that we've got to do much more outreach. We've got to connect much more with healthcare and take those referrals in. And I think the kind of advent of social prescribing is going to help that an awful lot as well, because that point around you as a GP needing to refer someone directly into that building, and we saw the data we look at, huge dropouts between that referral point and people actually making the front door. Whereas of course now what social prescribing will mean is people can find the thing they want to do that's going to be best for them. So we used to develop things like golf on referral schemes, where for a 65-year-old man probably don't want to go and do aerobics in the leisure centre or sit and stand classes, but would actually love to play golf. The benefit of green exercise, the social thing that comes with that societal change, that change in sort of normalising of behaviour was much, much more effective for that demographic. And of course, the list is endless then. So I think, making it relevant to that individual person is going to be the key to that. So hopefully, integrated care systems, social prescribing, those kind of ideas will be sort of impactful in doing that.
James, we'll come to ICS's, integrated care systems, in a second. But you mentioned in your introduction around in terms of the population that is most affected by this, and with the government's aim of levelling up, surely this is a focus that would help them with that levelling up in the sense of the investment in the sort of physical activity in places where it's a foreigner to you.
There are definitely clinical pathways that can be used to address obesity, particularly for some people, and that's going to be right. And there are some very interesting emerging technologies which would be interesting to talk about. There is also some really important fitness and physical well-being channels. And if we had someone from the education field, they would talk about the importance of education in schools. And if we had someone from transport, they would talk about walking and the importance of having fitness in the walking. In other words, there are many different channels that need to contribute to this. In the round, though, it is about a national mission. The idea of cross-departmental collaboration is just a total kiss of death. I mean, I never want to hear that phrase ever again. What I prefer, because it sounds more romantic and
collaboration of the willing, then, isn't it?
It is a sense of national mission. Now, we do have a sense of national mission about the climate, and that actually has pulled together a lot of people. It's caught the nation's imagination, and I think almost everyone in this country realizes that their organisation, their family, their government, their community has a role to play in achieving that. It's that sense of national mission that we need to have around fitness in order to address the gross disparities we have. And the obesity component has a really important role to play in that national mission around health. And the national mission around health, in terms of the Levelling Up white paper, the shorthand for it is longevity. And we know that we have these very big disparities in longevity, but we also know that healthy longevity has kind of stalled in the developing world. So that's the intellectual envelope in which I think that this conversation fits.
And unfortunately for the current CMO, he soon had to deal with a pandemic.
Yes.
His predecessor was accused of being nanny state, Sally Davis, when she was there. And I remember the interview on Channel 4, on Radio 4 in the morning, where she sort of confronted back. You wouldn't say that to a man.
Yeah.
But they had a point in that prescriptive and telling people what to do is often not liked.
Yes.
But giving them the right guidance on where to get help is. And do you think we're doing that yet?
No, I don't think we have resolved that one. I mean, I agree with, funnily enough, I reread Sally's book at the weekend, and I agree with almost everything she says. But component of telling people what to do is a tricky one. I think what people do understand is that the environments in which we live are really important. Now, I happen to be very concerned about pornography. I do not like the fact that my children have ready access to pornography. The environment in which they are being brought up in digital terms is going to have a big impact in their sexual health, in terms of their relationships. I think people understand that. And it is the same. The same is true with gambling and with junk food and with several other of the evils. And that idea of how the junk food cycle works and the environment in which particularly young people make decisions and habits around food is something that as a society we do need to address.
So sportsmen, women are seen as iconic. When Emma, winning the US Open last year, we have great golfers, we have fantastic footballers. There's a lot of diversity within it all. But apart from pockets, we don't seem to see them at the front of this national program, which is what you're talking about, or mission. Do you get involved with people like that to help you promote?
We do, and I think it's also potentially creates a barrier. So physical activity isn't just about elite sports or even club sports. It's doing the gardening, it's doing the ironing, it's moving around the house, and maintaining confidence in all of those things. So I think we have to think a lot about the inclusion part, and also how to make it the easy thing to do. So your points about design, I think, are really important. And one of my favourite stories was visiting a hospital where they were saying nobody goes to the Stop Smoking clinic, and the response for the designer was, "Where is it?" "Oh, it's in the basement between the lung function lab and the morgue." And we get into that habit of telling people what not to do without actually helping them do what they could do. And that happens in retail, just about any other sector is selling the positive. So a lot of what we're doing is trying to find the people who are positive, the networks that are positive, and joining them up. And that's going pretty well. We're starting to find networks of people who can translate the national policy down to what can we do here, and actually also inform the other direction, which is really exciting.
So Steve and James, you mentioned about innovation and new technologies. Could you give us some examples where you're seeing that at the moment?
Yeah, well, of course. Well, sitting here with a watch on,
we all are, aren't we? We're measuring everything we do as we sit.
Things, yeah, and it's
telling us that too.
That's an incredibly powerful tool, and the incentivization idea is incredibly powerful. But as Sasha pointed out, that type of thing could also have a negative aspiration. Well, if I'm never going to hit my 10,000 steps, what's the point? I'm not even going to bother starting. And that's a key issue we have to overcome. In that, one of the core principles of physical activity for health is that every 10-minute increment counts. It's not just about hitting those big targets. That every extra thing we do is important. And but those reminders from technology, the growth we've seen recently in people being able to do more at home. What COVID did in a kind of in the fitness world and the physical activity world is it made people go, right, my 4-wall gym facilities can't open, so I need to get some content to people at home in environments that they're more comfortable with. So now actually it's much easier to do an exercise class in front of the telly or off of your phone, rather than having to cross all those psychological barriers of getting into a facility, wearing the wrong clothes, worried that you're going to have to sort of stop after 20 minutes when the class is going for 40. So I think that's going to be hugely important. Really. Changing the environment within people can be active is going to be very powerful.
Well, I have found wearable tech has encouraged me to do exercise. I love it. I spend hours on it. I'm a massive enthusiast. I'm this perfect demographic. But in policy terms, in terms of a national solution, I think we have to be responsible about how much we attribute to nudges and techs for how much of this actual problem we're going to be able to address with them. Because at the place where we really have to begin, I think, is in two places. And these are technology points. One is a better understanding of how addiction, particularly to junk food, plays such a critical role. And that intellectual understanding that what we're talking about here is not self-discipline or weakness or some kind of moral judgment as we are prone to do. And I say that we generally because I count myself and my upbringing as being part of that mindset. We have to understand that with junk food, at least, we're talking about fats and sugars and salts that create great yearnings. And if you are someone who has either trauma in your life or issues that need to be addressed, those yearnings are very, very difficult to battle. And so we have to deal with them with some sympathy. And then secondly, we have to confront the fact that technology is being used against us because the algorithms and the use of modern social media and technology is currently being used to sell junk food really hard at particularly young people, but also people of all ages, and it's proving to be extremely effective. And if you look at, I take no joy, frankly, from the boom in Deliveroo and home delivered foods, because what I see in that is the delivery of extremely unhealthy foods at the moment. And I look forward to the moment when that changes. But at the moment, I see technology being used against the health of the nation too often.
So many years ago when I was a young doctor, my wife was a teacher in the East End of London. And that change started around that time.
Right.
It was the diet change, there was convenience. There was always fish and chip shops, there was always a curry house, but there was a sudden change in access to a lot of these foods. And I just think that would be in the mid-80s, and the change in our society since then, you're absolutely right. I think that it's around all those factors. And I'm always amazed when you watch a football match. First, I really get turned off by the gambling adverts. I just think it's harmful. And secondly, it's all large quantities, buy extra, you will get more food, you will have a family meal here, and nobody's done anything to produce it, and it seems a shame. And I remember later, my wife's career went into education and early years learning, and particularly setting up Sure Start. And it was the best opportunity we'd had to start that early years process of understanding your diet, and it fell apart. And I just wondered whether you were talking about working with other departments. Let's not call it cooperation. But is there a move to, incentivize the education service to actually become much more proactive?
Well, I'd like to see that steps being taken. Although people find Jamie Oliver annoying, he does have a really good point. I visited the Early Learning Foundation just around the corner from where we are today, and they have a Chefs in Schools Academy, and they are doing amazing things within a very, very tight budget, both to get their kids used to, at a very early age, to healthy foods, but also recognizing them and knowing the difference between them, and knowing what the attributes of the foods are. That's got to be a really great start in any young kid's life. And if the moment food arrangements for very young kids aren't heavily regulated, I don't like to bring in extra regulation if not necessary, but it would be great to see those kinds of practices rolled out more evenly across early learning.
Which brings me to one of the points I wanted to bring up later, so we might as well hit it now. We talked about integrated care systems, and your project shows that you can get your activity increase in any walk of life, and to do it. How one of the themes that we've got going in this organisation around the commission that we're looking at the moment is around adoption and use of best practice. How have you sort of communicated centrally, Sasha, if you don't mind me asking, about this, and how is it going to get to the ICS level? Actually, this might be a tool in the preventive strategies.
It's a really interesting question, isn't it? And I did my first big change project in South Devon when we were a so-called whole district trust in the early 90s, and that was fantastic because we brought all the aspects of health together and we were working very closely with the community, and I certainly felt a loss when that changed. So I'm really excited about the possibilities of ICSs, and I think when you look at the senior leaders of the ICSs, they're people who have walked this path for a long time, and they're really interested in not just hitting health service targets, but making a difference in the places that they're working. So I think the link to education is really important, and what we're seeing is it's local relationships, and you can't easily specify that in national guidance. So I think where we're getting to is working with the ICSs, sharing the connections, sharing the learning, and out of which will come the answer, as opposed to us trying to come up with the answer, telling people what it is and expecting them to follow it. We'll never do that nationally with the level of local flexibility that's required. So we're still at the joining up stage, and we're starting to see really interesting work in the north around Yorkshire. In the southeast, there's a fantastic network of active partnerships which have been set up from the local authority side, starting to work much more closely with health colleagues. I think there's a heck of a lot to play for in the next 6 months to a year as the ICSs formally pass the starting point to have these conversations and see what's possible.
Building on that, we've tried to adopt a sort of quite a data-driven approach to this sort of problem, to learn what best practice actually is. And what we do on behalf of Sport England is we collate data from across sort of 1,200 different leisure centres, fitness facilities. We overlay that with all the different sort of public health outcome data, socioeconomic data, and so on, to create this kind of map, this sort of real-time map. We've got a sort of data set now about just over 1.5 billion sort of data points from 25 million individual people, so we can start to understand what people are doing, where they're doing it, when they're doing it. So we know, obviously not personal information, but we know the age, some demographic information about those individuals. So we can start to see on behalf of ICSs and working with Sasha and the team, what is happening in Blackburn? Why are we seeing this kind of increase in activity, this kind of decrease in obesity? What can we learn from that as a case study, and how can that then be reflected in a, not necessarily a neighbouring place, but somewhere very statistically similar to that environment? So we can start to build a very clear picture, a live picture of kind of what's happening, and try and steer and influence practice when we can.
The traditional architecture of the NHS and working with local government has never been easy. In fact, hard to understand sometimes. In terms of the ICS, do you think that might actually simplify it in the sense of being able to get single messages across and trying to do what you would like, which is this sort of national process.
Yeah, I am really hopeful. I mean, the approach to ICSs came from the NHS family itself. It wasn't a top-down, ideologically driven reform. And every time we looked at the bill and engaged with the system, we got back smart, clever refinements. And that is everything to play for. And I think, Sasha, you put it extremely well. I think that this is a really good opportunity to try and get the different parts of the estate working together. And I agree that data is absolutely key. During the pandemic, it was a public health emergency, and we used a huge amount of data to great effect. We used a lot of diagnostic data, testing the hell out of the country. And we also used a lot of polygenic risk scoring, basically led by age, but other determinants, in order to do a vaccine rollout with 8 prioritization stages. And no one ever complained about which prioritization segment they were in. That was a hugely successful public health intervention. I would love to see that kind of energy and systematic approach to data applied to other diseases and illnesses across the population. And the development of ICSs and the collaboration with local authorities, I think, can really contribute to that.
We talked about smoking before, and Sir Richard Doll did his original presentation. I don't think many people really believed him at the time. It took quite a long time for that to actually come through. And I remember we once looked at a statistic for the Royal College of GPs about how successful GPs were reducing the number of smokers by giving advice. And it was something like 1%, which sounds terrible. But if you do that every year and the population doesn't start at the other end still,
I know, but
actually it's cumulative.
So that story breaks my heart a little bit. Not that I don't think the GPs weren't doing a good job, but because we have a tendency in this country to scapegoat the NHS, and we dump our health problems at the GP's door, and the GPs are sometimes only too happy to play that role. GPs can't fight smoking. You need the whole of society to do it. And we've got to get out of this mentality of blaming GPs for population health problems.
That'll be heartening to some of my colleagues at the moment, because they're feeling quite under pressure. We've been criticised. That said, we have to have strategies that they can at least signpost people into where they're going, because they do go up there on average 5.5 times a year. So they contact 5.5 times a year. So we can use them as a vehicle, I guess, as we can the rest of the health. But I totally agree with you that actually it's more fundamental where we need to do the education and the risks, etc. And I suppose we've got to come back towards the end of this. The disappointing news was slightly more disappointing to William Hague when you read his, I don't know whether you read his Times article from the 70s. That was a no holds barred. I won't quote it because it's there for people to read. But it was almost accusing the government of really a morality issue here. Yes, there are issues around nanny state and telling people what to do, but actually not supplying people with the right information is not good conservatism as well as not good for governance. Is that how other people see it, do you think, at the moment?
Well, I can only speak for myself. I think it was a huge mistake. It was bad policy making because these are essential measures that are agreed across the piece. And I think it's bad politics. My view is that British families want the government's help and support in fighting a problem that they recognise. Mums and dads want their children to be healthy. They want themselves and their partners and the ones they love to live long and healthy lives, and they want support in trying to achieve that. It is wrong to think that the British public is craving for treats and is just thinking about where the next donut is. I think that it's a misread of the situation from a political point of view. The damage is quite severe, I fear, because our partners in the medical research charities, in the food industry, amongst retailers, amongst advertisers, take us at our word that this obesity crisis is something that is really serious for the nation. And they have, in many ways, stepped up and made measures and sacrifices for themselves to contribute to the overall plan. So when we back off for seemingly frivolous reasons, we lose that confidence and that momentum. And I hope very much indeed that we can build back that as soon as we can.
On that very candid note, I think we'll stop. Thank you very much, all of you.
Thank you.